Hi, I'm Dr. Farzad Mostashari. I guess it's obligatory in this to state, yes, I trained in internal medicine, but went right into more of a public health and started the New York City Primary Care Information Project, focused on how technology can help primary care take better care of the public's health. Served in the administration, same time as Liz. We would have these secret coffee chats, and she and I would both show up sweaty from biking, which in her honor today, I wore my biking shoes to interview Liz Fowler. I now lead a company called Aledade, and we work with primary care providers, about 1,000 practices across 38 states. We are the largest enabler of risk-taking primary care in the country. And this year, we hope to give $200 million to primary care practices because of their demonstrated success in improving patient care and reducing cost, which we're really proud of. So very pleased to be speaking with my friend, Liz Fowler. Hi, Liz.
Hey, how's it going?
Good.
Farzad, nice to see you. And you biked today, and I drove. So yeah, unfortunately. But it's nice to see you, and I'm really happy to have this conversation. It feels like we've been talking about primary care together for a long time. So it seems like a natural extension of our coffee conversations.
Yeah, exactly. Liz, how do you think it's going in terms of primary care being able to, in terms of the goals that you've articulated, how are we doing against those goals?
Sure. Well, let me, maybe I need to introduce myself. So I'm Liz Fowler. I'm the director of the CMS Innovation Center and also the deputy administrator at CMS.
Everyone knows Liz. Come on.
That's not true. But so we announced a strategy last fall that is really dependent on primary care for its success. We said we wanted to see 100% of Medicare beneficiaries in accountable care by 2030, and primary care is really at the heart of that strategy through either an ACO approach or an advanced primary care approach. So we're really counting on the success of models like yours and other organizations in primary care to really help us deliver on that strategy, because we think it delivers better care and better outcomes for patients. So we announced it last fall, and you heard from Dora, I'm sure, about the equity elements of the plan, and we're now set on execution and delivering on those bold, ambitious goals.
Music to our ears. And so, I mean, one of the goals that you set there was that on the Medicare side, getting to 100% by 2030, which is, I used to, our good friend David Blumenthal was my boss, who was here.
He was my boss too.
Yes. So when under David, we were asked by OMB to give targets for meaningful use of electronic health records, and and this regional extension center program that helped primary care docs adopt electronic health records, and we gave numbers and we gave dates. And a veteran SES said to me, no, you don't do that. You can give numbers or you can give dates. Don't give numbers and dates to OMB.
Because then they'll hold you accountable?
Because then you can be held accountable. So Liz, you gave us numbers and a date.
Yeah.
But the date's like way off. It's like 2030.
It's not that far away.
Well, but how are you thinking about breaking that down into shorter increments and being like, okay, in the next 3 years, we're going to get X number more?
We're trying to get to that point. I think, and you know, those of you who know Dr. Mina Seshmani, who leads the Medicare program and the Medicare Shared Savings Program, we're working, this is a shared partnership.
Been great to see,
and
yeah.
We really want to make sure that what we're doing informs and helps advance what they're doing, that we're testing things that are going to be useful and helping grow the Shared Savings Program. So we're doing this in partnership, so it doesn't all sit on the Innovation Center's shoulders, but we need to be thinking about the next models. And I think the reason I say 8 years doesn't seem like that far away is because it takes a while to get these models up and running. You know, we're thinking about the next, you know, we're very pleased with the direction that Primary Care First is going, and but thinking about what comes next and what comes after that. So for us, it's a constant push forward.
Yeah, no, I think that is such a huge step. And I think it is, you know, in this town, relationships matter, and the fact that you have such a great working relationship, I think, is meaningful. And in the New England Journal, you talked about using the shared savings program, which is the largest, really, I think, the most, you know, primary care accountable model in history that's been very successful, met the CBO projections, billions of dollars in savings, right? And many of the CMMI models that proved successful were ones that actually built on top of the shared savings program, like Track One Plus or AIM. And I loved seeing that in the New England Journal paper, that using Center for Medicare's vehicles as a chassis for experimentation with CMMI, I think that's fantastic. Can you give us, you mentioned a couple of things in the paper, can you give us some hints about the kinds of things you might want to test on that chassis?
Sure. Well, I see the role of the CMS Innovation Center as twofold. We've got to make sure there's opportunities for folks that want to come in and want to become advanced primary care practices. So we have to create those pathways. AIM was one of those pathways. I think it's ready to see what we can learn from those lessons, hand those lessons.
Advanced investment model.
Oh, sorry.
Giving money up front to
ACO
practices.
investment model, right. Yeah. So right, that's right. But I think that's one way of bringing practices into ACOs if they want to go in that direction, and we're handing those lessons over to our colleagues in the Center for Medicare. But the other thing that we do is really test on the front end, and that's what the Global and Professional Direct Contracting Program, soon to become the ACO REACH program, is doing. It's testing some of the primary care capitation approaches, for example. If those work, if that looks like it's a good path forward, lessons from that can be brought over to MSSP. So I think that's another example of something that where what we do can test concepts that could become part of the program, the larger program.
One of the other things that you mentioned in the paper was beneficiaries, right? Can we help create pathways for my mom to see a benefit if her provider is in an accountable relationship? It's obviously like brilliant and hard to do. Any comments on how we think about getting beneficiaries to be getting some of the benefits of these two in a more obvious way?
Well, I think what one of the things that we've discovered maybe over the last 6 months is that we don't do a very good job of explaining what it is that primary care brings to patients, what an ACO brings to patients. And so that's something that we're really focused on. We, in fact, just had a meeting with beneficiary organizations this afternoon, and they were saying, you have to do a better job of explaining how is this not managed care? Because it isn't managed care. No one is limiting your ability to see a specialist or to go see another doctor of your choosing. We're not constraining you. We don't use prior authorization.
Get more. You're only getting more. No one's getting less.
Yeah, so we just need to do a better job of explaining that. So we really are trying. We put on our website a video trying to explain what an ACO is, and we are trying to do more of that. We've done some focus groups on what, it turns out that the language we're using isn't really resonating with patients. So we need to be able to explain why this is better care. Sometimes using examples helps, patient examples, but this is the beginning of our journey to figure out how to do a better job. So,
can I give you my idea?
Yeah, as always, I am open to your ideas.
So I think we should, if a patient goes to their accountable primary care doc, I don't think they should pay a copay. So I think we should make primary care free, and that 20%, if they have a copay.
Could you do that on your own? Do you need us to do that?
Well, our docs our primary care docs need it to make payroll.
I see.
So if we don't collect it from the patient, can Medicare make up that, test a model where more primary care, because we've dropped the price for the patient, strengthen the relationship with primary care?
I mean, thinking there are examples out there, what the Affordable Care Act did with preventive services, for example.
Right.
And, we want to encourage patients to do are things that we want to make it easy and affordable for them to do. So, I mean, I'm not going to make any promises here, but happy to.
If it happens, guys, that'll be pretty cool, right?
But yeah, I mean, even I remember the discussion over health savings accounts, like what is exempt from a deductible, and
Exactly.
what do we want to encourage patients to be doing and using more of. And
think of it as a really, really skinny med sup plan for those who don't have it, just for accountable primary care.
Interesting. Okay.
Okay. All right. All right. We'll talk about it. One of the things that we always talk about is reducing burden, and I actually want to just state right off the front, like I think CMS has done a better job than any private payer at reducing the number of quality measures, pushing towards, right, and in the program we went from 22 to 18 to 13 to, we're going to get to 3 electronically reported quality measures. How do you think we can encourage more private sector kind of collaboration following in the footsteps? I know it's been something we've talked about. We always talk about it.
Right.
But do we see reason for optimism there?
I think so, and we've made multi-payer alignment one of the sort of pillars of our strategy because of the administrative burden, and knowing that for a lot of practices out there, when you have sort of the 1 foot in 2 canoes, and you're trying to manage, the value-based care side, and then but you've got the fee-for-service side, and I think, the way we've thought about multi-payer alignment in the past is sort of come join our model, come join Primary Care First or CPC Plus, and I think we still want to encourage participation, but maybe there are other elements where we can align, like on quality metrics. So we're looking down that path and trying to figure out how to do that, and I see Mark over there and is a partner in thinking how to do that. So,
yeah, one of the things that I think sometimes happens in the multi-payer groups is they all agree that they should add these 10 measures, but not take anything away. And so I think what practicing docs out there are feeling is too many measures. There's just too much measurement, and actually we don't necessarily move what we measure. We can sometimes, with too much measurement, we can actually lose that focus on what really matters.
Well, in a fee-for-service environment, in a MIPS framework, of course you want more measures and trying to hold providers accountable, but as you move up the value curve, right, and you're really thinking about a more population health approach, you really want to focus on the measures that matter and not, you don't need that any longer because you've got the accountability in other aspects. So
exactly, right? So you don't need to measure our primary care practices on whether they give the flu shot or pneumonia shot, because they're incentivized to do that because they want to reduce pneumonia admissions, right? We don't need that sense of monitoring. And I do think that asking the question, right, what's the most important thing, right? What's the question that we want our practice to be thinking about? How do we save the most lives, right? The answer to that is blood pressure control is how we save the most lives. And it's also the answer to how do we reduce the greatest racial disparities in deaths, right? Is the rates of blood pressure control among our African-American Medicare beneficiaries are significantly worse. And we're really, really working on it. We're stratifying the data. And kind of to the previous conversation, we would love to see that sort of stratification focus and potentially some incentives for groups that serve those patients and can make benefits in those. What do you think? Can we align financial incentives with it?
that would be great. Let's talk about it. Maybe over coffee.
I got 2 things. On the health equity side, what else in terms of on the docket? I'll tell you, we at Aledade, we have 154, I think, federally qualified health centers that we work with, about, I think, over 10% of all federally qualified health centers, and they're fantastic. Like, they have what it takes to succeed. And
That's great to hear.
Right, and the majority of our lives are in health professional shortage areas. Like, there is nothing to say that we can't succeed in those areas, but the challenges are greater. And just how do you think about, in particular, encouraging participation from those communities?
Well, and I'm sure you heard, as Dora described our strategy, I think making sure that we're bringing along safety net providers, FQHCs is...
I heard Dora on the live stream say something like, I don't know what's public yet and what's not public yet, so that gave me, that's a good sign. That gave me hope that, like, there's something good that's going to come.
But we're doing a lot of thought on how to make sure that what we're doing benefits everybody, including those that care for the most underserved, and that includes rural populations as well as historically disadvantaged populations. So making sure we have those providers in the programs. I think making sure we're collecting data, and not just race and ethnicity, but also thinking about social determinants. So I think you'll start to see that in more and more of our models. And then we're trying a couple of things in that are unique in CMMI models. One is a payment adjustment. If you saw in the ACO REACH program, if you're a provider that cares for a higher proportion at the top decile of beneficiaries from underserved populations, we'll give you a payment bonus. And so really testing the limits of trying to make up for some of the historical underfunding, and then also just also including a requirement for a health equity plan. And I think we're going to start requiring that for all of our models. What are you going to do to reduce disparities? And then going back and looking to see whether or not those disparities were in fact reduced. So.
We're working with primary care practices in all sorts of settings, all sorts of primary care practices. If you had a question to ask of them, what would you want to know? I can find out for you.
For a practice in your...
primary care practices who are really engaged in the work and the hard work of actually trying to deliver better care and lower costs and make this a new business model for themselves. What are you curious about?
I mean, what's still getting in your way? Okay, so we've made a lot of practice. You've made the jump. You're considered advanced primary care. What else is it? What else should we be doing? What else should we be thinking about? I think we're always looking for sort of that next, how do we make even more improvements or make it even easier for you? So that might be one aspect. And then how do you explain what you're doing to your patients? Like I said, we need a better conversation and to be able to explain what we're doing. So tell me more about how you explain what it is you're giving to patients. You said you get more. So, explain, how would you tell me, a layperson or a patient, what that entails?
Yeah, I mean, most of our practices don't give their patients a big explanation of like, I am now in an accountable care, right? It's just, if their patient goes to the emergency room, they get a phone call from the practice that says, how are you feeling? Like, that's what has changed now. When they show up, the doc at the point of care sees that they haven't filled their prescriptions because we're getting data from the pharmacy. Like, they're just getting more engaged, more informed primary care. It's more still coordinated,
better managed.
Right. It's still it's still the same doc. It's still the same. Like, nothing. Like, again, as I said, like, you're not. There's nothing different except it's better. And I don't think we necessarily need to make it feel like anything other than just better primary care, except if we can say you get free primary care. That would be right. That would be good.
You think that would be better?
I think that would be good. Okay. Yeah. I do think in terms of the challenges we still have, and this is pointing the finger at myself to some extent, interoperability is still really hard. And despite a lot of work by a lot of people, and one of the things that we still, I don't know if this isn't your part of CMS, but one of the things that AFP advocated for was making it a condition of participation for hospitals, that if they discharge a patient, they send a notice to community physicians about that. And that was, in fact, it was finalized, but the guidance and the rules and the penalties and so forth haven't been implemented. So that is something that we still, our primary care docs don't hear about unless we do a whole lot of work in the background. They don't get notices when their patients are discharged from the hospital.
But it feels like we're making more progress
We
on
are.
interoperability. I had a whole conversation with your successor.
Mickey's,
Yes.
yeah, finally got someone who knows what he's doing in there.
But it sounds like we're making a lot of progress and that we're closer than ever in that direction. I don't know if you'd agree with that. But
Yeah, I think from a technical standpoint, there's fewer barriers, but from a business model standpoint, people still don't necessarily want to share data. Consolidation, speaking of hospitals and potentially anti-competitive behavior, there's a lot of evidence now that independent practices, when they are closed down, that the care in the community gets worse. There's less choice, and systems getting bigger and bigger and bigger don't necessarily result in quality of care going up or costs going down, even for Medicare, and certainly not for commercial payers. Do you think that there's a competition agenda that the Biden administration put out and the president put out an executive order? Do you feel like we should be thinking a little bit differently about smaller independent practices and making sure that we continue to support them in being able to thrive and stay independent?
yeah, absolutely. If we can do that, we should. And having worked for a number of years for the senator from Montana, I know how important those providers are to a community. It's really critical. And having also grown up in Kansas, I should say, rural health, a lot of background in rural health, and really understand that the value of having that provider in that community and what it means to patients. So, we are looking at that and thinking about that. Stay tuned, but it's definitely on our radar. So, stay tuned in CMS, speak.
Parlance.
Yeah, it might
could be years.
Right, it might not be tomorrow. So, just fair warning.
Great. Liz, any questions? Any questions that you have for me or the audience?
Well, I guess it was an honest question. What more should we be doing? We're trying to move as fast as we can. We value input. That's the reason we had the primary care open door forum. We really want to hear from all of you about what more we could be doing, what more we could be doing differently. To your point about competition, we hear if we hear about bad behavior or somebody's doing something that seems like, well, that doesn't seem quite right, we're referring them on to the Center for Program Integrity. We're looking very closely. We want organizations in our models to be in it for the right reasons, and that is to deliver better care. So when we hear things that sound anti-competitive or predatory, we take that very seriously. But maybe my question again is, what more should we be doing? What do you want to see from us?
Yeah, I mean, one thing I'll say is I think you're correct in when you put out your strategy that what people want to see from you is not necessarily more different, 12 different ways, 12 different kinds of models, but really coalescing around a smaller number. And as you said, the most successful models have been those that gave accountability for the total cost of care to primary care and let them do their job. And I do think that if you gave primary care more tools to control downstream costs, it might be even more effective than trying to create more and more specialty-specific bundles, but that's probably conversation for another day.
Yeah, well, I mean, the whole question of how you handle specialty care and how specialty care integrates with primary care is an active conversation. We're having active discussions on what we do in that space and what that looks like. So that's another area where we've really invited feedback and had a lot of conversations with outside experts like yourself, but figuring that out. If we do bundles, if we do episodes, we want to make sure that they're ones that integrate well with an ACO or a primary care practice. It's not going to step on their toes, or you wouldn't want to do like a cardiology bundle where you're taking all the patients away and giving them giving providers a reason not to join a primary care practice or stay in an ACO. So we want to make sure that what we do is complementary and not overlapping or conflicting.
And you mentioned some of the benefits that folks in Medicare Advantage can, or I think actually Dora said in the previous session, and I also think that you've said we want to level the playing field in some ways, right? Can we find ways to take some of those things that are possible when the payment's more of a capitated payment and there's more flexibility? Can we find ways of bringing some of those flexibilities over to the physician-led ACO side of the house?
Yeah, there's a lot of talk about how do you level the playing field.
Yeah.
If you're a beneficiary and you don't want to be in Medicare Advantage, how can we make sure that we have a viable, solid choice that's going to offer people the benefits, the benefit enhancements, the coordination, what you think you might get from Medicare Advantage, maybe without the narrow network.
Exactly.
I mean, no aspersion. I'm not trying to cast aspersions, but that's the way
Exactly.
thinking about my mother-in-law and my mother and where they want to get their care. I think they want to stay with their primary care practice. And I didn't mention my dad was a primary care physician.
Well,
and
there you
my
go.
grandfather. So.
Well, fantastic. Sean, do you want us to take some questions from the audience? Yeah, it's a great opportunity. We certainly put out a lot of food for thought.
While they get their questions ready, Liz, thank you for being here, both you and Farzad. I have a question from the AAFP perspective. We've thought a lot about on-ramps and then keeping people on a path towards innovation and transformation. One of the things we've noticed, particularly in family medicine, is they might come into CPC or CPC Plus, but then they leave. They don't progress to other innovative models over time. It's a true demonstration. And I know you've been thinking about that, but would welcome your comments about how do you keep them on an innovation path over a longer period of time?
Yeah, well, I think first, one of the observations and maybe I'd say one of the lessons learned from our previous models is that we may need longer term models, that 5 years might not be enough to demonstrate the savings that we're looking for, and we want to make sure that transformation is going to be lasting. So maybe one lesson is to think about looking at a longer period of time. So I think that's maybe one aspect of an answer.
I mean, I'll say one of the things that is very helpful is a feeling of momentum and a feeling that the work you put in is rewarded. And when practices feel like they did a lot of work and they didn't get, it's just a lack of connection between action and outcome, it's very discouraging. And if they feel like they got savings one year and then the next year, like the savings aren't there, that kills momentum. And I think creating that by like a sense that if you keep doing the work, you can find value-based models and outcome-based payment a bigger and bigger part of your total compensation. I think it's important. The connection to ACO REACH, I think, and maybe something that can be brought into the Medicare Shared Savings Program is not having to wait 18, 19, 20 months between when you start doing the work and you get a check.
Yeah.
And being able to move reconciliations sooner, maybe quarterly, preliminary. I mean, this is what Medicare Advantage plans do, right? They say, oh, it looks like you're going to get this much savings. We're going to give you maybe an advance of half of it or a third of it or something. But moving up the cash flows would be, I think, a partial answer.
I think multipayer alignment might also.
That thing
too. I mean, if you want the lasting change, you've got to make sure that it's.
Yeah, that's correct.
The other payers in the system are right there supporting that change and that transformation as well.
And there may be more levers on the exchange side, as our friend Peter Lee showed in California, potentially on the Medicaid side as an MA as well.
Yep.
Yes.
Hey, thanks for a really interesting conversation. I'm Patrick, and I'm the Chief Medical Officer for a large employer's self-funded primary care network. So basically, we own all these primary care networks or clinics across the country and provide care actually for free at the point of service. So for us, when our employees come to see us, there's no money exchange. They get to see their doctor and have an interaction. One of the things that we're trying to figure out is, despite that, engagement isn't what you might hope or imagine. And I tend to think of this as a design problem. It's either an inconvenient location or an inaccessible type of interaction or a type of interaction that's just not particularly suitable for someone to want to come back and have it again. So I'm curious, when you think about doing this on a national scale with many more clinics and many more doctors and many more patients than what we have, how do you think about building in a structure for incentivizing the clinics to create that type of interaction that suits the patients, not as measured by some sentiment analysis, but maybe more as measured by actual meaningful engagement? I am mostly from a hospital background in my clinical life, and HCAHPS is not a great tool anyway. It's nice, it's got a lot of value, but it's tough to fill that out and think that anyone's going to give you a real deep understanding of their actual satisfaction. So how do you shift from that type of format towards understanding the end user's engagement as a trigger for the value of what's being offered?
Yeah, it's a really good question. And I think, as Dora explained, we're really trying to incorporate equity into every aspect of our models. We're also at maybe an earlier stage of thinking about how we incorporate beneficiary perspectives into all aspects of our models. And I've said this in previous settings, we spend a lot of time talking to doctors and hospitals and health systems and payers, and a lot less time talking to patients. And so we are working on a strategy, hopefully going to announce soon how we intend to do that and the steps we want to take in models. But I think you'll start to see more requirements that start looking at what beneficiaries are looking for, and not just caps. So earlier stages, but definitely on the to-do list.
I mean, from our perspective, I'll say the first thing that we work when a practice joins Aledade, and these are fantastic community practices who've been doing primary care in their communities for years, decades. But one thing they'd never done before, in many cases, is active, proactive outreach. It has been mostly like their schedule is full and there's a primary care shortage in America. They don't need to reach out to anybody. Their schedule can be absolutely full all day of people who called them to schedule something. But what that misses is who's the person who hasn't called? Who's the person who you should be worried about, right? And so much of primary care, particularly, when you're trying to fit more and more patients into fewer and fewer minutes because you got to pay your bills and the payer isn't paying you anymore, right? Ends up being reactive, and you lose sight of the members of your flock, right? If you're the shepherd, who are you not hearing from? And that is where I think the alignment of the incentives, so that you actually can create a huge value for that patient, for society, and for your practice by proactively reaching out to them, and the data and the technology to be able to identify those highest risk patients, highest need patients, and then create a workflow for reaching out to them. And then, I believe that in the future, like telehealth was a huge advance for us to be able to create different modes of reaching out, and obviously during COVID, it became essential for survival. And I think I've told Liz, like we stood up 150 practices on telehealth over a weekend so that they could start seeing patients on Monday, right? So, but right, a lot of the outreach that our practices are doing to patients, particularly seniors, is telephone, and that's okay. But like creating the incentives and then the tools for engagement with patients is essential. What the practices don't need help with, right, is they have a relationship. They actually have a relationship. It's not the convenient care. It's not the app on the phone. It's not the video, whatever. It's some random anonymized, provider, right, on the phone. It's a family physician who they have had in many cases, generational relationship with. And I think we can try to strengthen that, but we can't think that we don't need that. We can work around that. More questions? All right. Thanks so much.
Yeah, thank you. Thanks so much for having me.